Fantastic. Well, hello, Internet world. My name is Dr. Garrett Booth. I'm an associate professor of pathology, microbiology, and immunology at Vanderbilt University Medical Center in Nashville, Tennessee, in the United States. I will be your web host, guest, and Internet explorer with you for the International Academy for Clinical Hematology. And today's topic will be cold agglutination or cold agglutinin disease, laboratory evaluation and treatment options. I'm a pathologist by training, but we'll be touching on both the diagnostic elements as well as some pitfalls within that. So we're going to go ahead and get started. Today's date is March 12th, 2019. So if you're viewing this in the future state, um, welcome back into time. So from an overview perspective, we will be covering some general topics related to immune-mediated red cell destruction. Really what we're going to focus on is how and why are the immune system interplay with reducing the circulating lifespan of red blood cells. We'll spend the overwhelming majority of our time talking about cold agglutinin disease and the diagnosis. What are we doing in the clinical laboratory? We'll talk about some pitfalls, including some literature that we've published as it relates to physician ordering and some maladaptive ordering practices. And then we'll close out with some treatment options, including what can be done immediately, what should be done immediately, and what are some long-term complications and treatment options. So again, just by way of background, there are about, if you believe the World Health Organization, which I do, about half of the global population has anemia. The overwhelming majority of etiologies as it relates to anemia is from an infectious etiology. So what we're going to be talking about today is that it has nothing to do with that by and large. We'll be talking about the interplay between the immune system and the hematologic system as it relates to immune-mediated red cell destruction. So on the left-hand side of your screen, you'll see this is what we'll be talking about: autoimmune-related diseases. We'll touch on warm autoimmune hemolytic anemia, spend, as I said, the majority of our time talking about cold agglutinin syndrome. There is a diagnostic category for a mixed autoimmune hemolytic anemia and some other rare entities which I'll touch on. But don't forget, if you have a suspicion for immune-mediated hemolysis, that you also need to be able to evaluate patients for alloimmune causes, particularly in certain patient populations, including sickle cell disease or other thalassemias, any patient population that's heavily transfused, because they may be subject to a hemolytic transfusion reaction, or in any situation where you're using uncross-matched trauma blood that is not blood type O. The HDFN is hemolytic disease of the fetus and newborn. For the adult audience, this is largely something that you will not see, but for the obstetric or pediatric related audience members participating in this webinar, this is largely a subset of immune-mediated hemolysis that are maternal antibodies that cross the placenta via syncytia trophoblasts that result in fetal red cell destruction that can range anywhere from mild to a little bit of biliary lights to very clinically severe, including hydrops fetalis or in utero death. And then there's always drug-induced immune-mediated hemolysis. One of the more frequent questions I get are, what medications are involved in this? And they make for great board questions, including, first and second generation cephalosporins and penicillins. But the reality is, if you look at medication registries, of which there are several, there are multiple medications that have been implicated in immune-mediated hemolysis. Again, this is outside the scope of today's discussion, but I just wanted to provide that by way of background. And then, as always, anytime you're doing a diagnostic evaluation for immune-mediated hemolysis, always consider passively acquired sources. So in the United States, source plasma can be fractionated into products that are sold, things like IVIG or RH immune globulin, which again are from plasma donors, often thousands, if not tens of thousands of donors, and they may have, in addition to wonderful amounts of immunoglobulin in there to help fight off a disease state, may also harbor clinically significant antibodies, including antibodies to minor red cell and antigens that could result in hemolysis. So always take a good medication history when you are evaluating a patient in that respect. Okay, so we're going to talk about autoimmune hemolytic anemia. So let's just jump right in, Internet. So again, signs and symptoms. This is a rather background or cursory related slide, but remember that there are lots of different ways that people can present with anemia. This most often happens when a patient's hemoglobin level falls below whatever critical threshold, right? So if they are at rest or exerting themselves, that's when they start to feel the effects. They may also travel, particularly to high elevation areas. Or if you have a moderately low hemoglobin, but you don't have an adequate cardiopulmonary reserve, then the patient can present clinically. And basically anything in between those two things can also happen. So let's talk about um, how we're going to just generally touch on laboratory evaluation of anemia. Your gold standard, your readily available, very cheap to do is a complete blood count or CBC. It's very safe, it's very cost effective, and just looking for things like hemoglobin. Remember, hematocrit is a calculated variable, but it's important to also check red cell count and all the other indices. Remember that what is considered normal can vary by gender, it can vary by age, it can vary by sex as well as race. So outside of the scope of today's discussion, but there are WHO criteria or NCI related criteria. But remember that even within the human population, there are people that live on the extremes, including at high altitude. So in the United States, people that may be living in Denver, Colorado, may have a higher basal hemoglobin value than, say, people living in Nashville, Tennessee, which is closer to sea level. Olympic athletes also unbelievably healthy and may have all sorts of variations within their normal indices. And then, as always, smokers. Here in the American South, the background rate of tobacco consumption via smoking, pipe, cigarette, or otherwise is about 20%. So it can have impacts on hematologic indices. Just be aware of that. Okay, so whenever you're assessing the anemia, as we touched on, you're going to put all these indices in the appropriate clinical context. But also remember, readily available and easy to collect specimens like urine. One of the first things that happens to change color is that you'll have elements of jaundice. Most people are able to identify the normal color of their urine, whether it's first void in the morning or being able to identify that it just looks different or abnormal. And then, as always, there's a small army of hematologic laboratories that can also be ordered, including LDH, haptoglobin levels, and bilirubin. Remember, haptoglobin is a positive acute phase reactant, meaning that when people get ill, get sick, or stressed, their liver, which produces this tetrameric protein, should cause the levels to rise and rise rapidly. However, in the setting of anemia, haptoglobin does an outstanding job of scavenging free hemoglobin to avoid the downstream consequences, including nephrotoxicity. So always putting it in the appropriate clinical context, as well as trying to understand whether or not they have underlying liver disease, becomes essential. In my opinion, one of the most overlooked and underutilized clinical laboratory tests is that of a peripheral blood smear. This may simply be because people are less comfortable, less familiar, or less willing to take time out of their clinical practice to use a microscope, but I'll show you some pictures just for some hints on things to look for, particularly in cold agglutinin disease. And then, as always, your clinical exam, assessing spleen size, and no joke, ensuring that the patient does not have ongoing blood loss. This often is one of the questions that I will ask my clinical colleagues, and they'll say, well, I didn't assess that, or I didn't consider that. So always making sure that you ask the appropriate questions becomes essential for any type of anemia assessment. All right, so what about warm autoimmune hemolytic anemia? Well, warm autoimmune hemolytic anemia is the overwhelming majority of autoimmune hemolytic anemia cases. It's about 75% of all total cases. The overall incidence is about 1 in 75 to 80,000. It's typically IgG mediated. I'll show you a slide with some of the more common laboratory findings. But this is a typical autoantibody that reacts with the patient's own red cells, typically at warm temperatures, including core body temperatures of up to 37 degrees centigrade. It can happen in all ages. However, there's a peak incidence of warm autoimmune hemolytic anemia for people in their 8th, 9th decade of life, and it can be highly variable. Some patients may have a mild smoldering anemia that is otherwise non-impactful for their daily life. However, others can be secondary to other hematologic malignancies, including chronic lymphocytic leukemia, other lymphomas, or lupus. The good news is most patients will be responsive to steroid treatment or other immunomodulatory drugs like rituximab. Um, it doesn't happen immediately. It can take several weeks, but 80 to 90% of patients when treated with steroids and or rituximab should have a clinical response. Also, recognize that in patients with warm autoimmune hemolytic anemia, there is a increased rate of thromboembolism, especially if the patient has a history of a lupus anticoagulant. So getting an accurate rheumatologic history is also critically important. I also put in the bottom of the slide there, Evans syndrome. Evans syndrome is more likely to show up on your board examination, but it's something to keep in mind. These typically are not concurrent, but Evans syndrome by definition is patients that have a combination of warm autoimmune hemolytic anemia as well as an immune-mediated platelet destruction. Typically, these things can be separated by several years, if not decades. So it's important that if you're seeing an adult patient and you have a clinical concern for warm autoimmune hemolytic anemia, that you also ask about their distant history, including childhood history for things like ITP, so that you can have a more comprehensive picture and say, well, I think this patient may actually have Evans syndrome. It would be very rare for them to happen at the same time, but not an impossibility. So this is what a typical laboratory testing panel might look like. For those that aren't familiar with terminology like direct antiglobulin test, that is a more modern laboratory terminology for what historically was known as the direct Coombs. So you'll see down the column on the left-hand side, your IgG, that's just the isoform. C3 is a complement fragment, and then these are just percentages. So what do we see here in the laboratory when we have patients with warm autoimmune hemolytic anemia? About half of patients will have both immunoglobulin and complement deposition on their red cell. Um, and you don't have to be at 37 degrees, but it can. We'll also be able to see autoagglutination sometimes in about a third of cases. But notice the spread here of the testing pattern. Only about a quarter of cases of warm autoimmune hemolytic anemia just have IgG on the cell surface. And a small subset will also have just complement, which again becomes critically important when doing an evaluation for patients with cold agglutinin disease, because that's the pattern that you would expect to see in those cases. Okay, so what about IgG that's cold-mediated autoimmune hemolytic anemia? This is also known as paroxysmal cold hemoglobinuria, or PCH. Has nothing to do with the Pacific Coast Highway, but if you get a chance, that's a lovely ride up the west coast of the United States. Remember, this is clinically very different than paroxysmal nocturnal hemoglobinuria, or PNH. One of the more common reasons we have laboratory errors is people are just simply clicking on the wrong box within the computerized physician order entry system, and they're confusing PCH and PNH. Remember that when you think about paroxysmal cold hemoglobinuria, this is typically a disorder in childhood. It can be about a week to 2 weeks after a patient's presenting with upper respiratory related illness, and they may come into the ED with complaints of fever, malaise, abdominal pain, or parents might note darkened urine or jaundice or pallor. Now, these are the antibodies that are typically IgG, and they have specificity to the red cell antigen system, or the P antibody. These also are known as the biphasic hemolysin, in that it tends to bind at colder temperatures, and it doesn't have to be the ambient temperature. It could just be colder regions on the body, for example, in the fingertips, nose, and ear. So the IgG will bind at those extremes, but as the blood returns to the core body and warms up, that antibody dissociates. But what you're seeing is actually the complement deposition from that complement cascade activation. This is relatively a frequent cause of paroxysmal, or relatively frequent cause of autoimmune hemolytic anemia in children, but remember that this is typically a disorder that happens in young children, typically 5 years of life, with a slightly higher male to female predominance. I'll show you a picture of what neutrophil-mediated erythrophagocytosis looks like, but also remember that you could see this disorder in the adult population, but it's typically associated with a chronic syphilitic state or tertiary related syphilis. When we look at adult patients and oftentimes providers may circle the whole form or click on every box because they want every subset of autoimmune hemolytic anemia tested for. Uh, I have not seen a case of paroxysmal chronic hemoglobinuria in an adult patient, um, but it's not to say it's impossible. PubMed is littered with random case reports out there, but there may be a selection bias for those types of cases, so just be aware. So what is a Donath-Landsteiner test? In addition to being very labor intensive in your diagnostic laboratory, the purpose of this test is to try and identify that biphasic hemolysin in the patient's serum. So you have to set up a number of tubes, and I'll show you that, I believe, on the next screen. One set of tubes will be the patient's serum and donor red cells. This next tube will be patient serum with usually fresh normal serum and donor red blood cells. Part of the reason why pathologists like myself don't like this test is because often we have to find someone to be the source of fresh normal serum, and that usually means we have to stick a medical technologist. So that's why there's a lot of resistance to doing this test on the adult population when the pretest probability is very low. And a third series of tubes of fresh donor serum and donor red cells. A positive test would only show hemolysis in tubes 1 and 2, but not in the tube 3 set. And only tubes that were initially incubated at cold temperatures and then subsequently incubated at higher temperatures. Again, what we're doing there is we're just trying to allow the IgG to bind to the P antigen at cold temperatures and then warm it up, provide sufficient incubation time, we'll be able to see that red cell hemolysis take place. Note that you can have low titer Donath-Landsteiner antibodies and they can persist for a very long time. There's been reports up to 8 years, but typically the patient will not be symptomatic for that duration. And this tends to resolve on its own, often not requiring any type of transfusion support. So here are the series of tubes, and you'll see that the color change is very obvious when you have a case where you have patient serum and donor red blood cells that resulted in that biphasic hemolysin. Remember that the normal color of human plasma tends to be straw colored. For those people that aren't familiar with what straw looks like, it looks like a light lager beer, like Miller Lite or Coors Light, whatever cheap American beer you fancy the most. And again, this is just an image taken from blood. This is what erythrophagocytosis looks like, and you can see the neutrophils, these polymorphic neutrophils, just ingesting circulating red blood cells, which can obviously reduce the circulating lifespan and result in anemia. Again, you can see this in the adult population. That was a case report of a 65-year-old, but again, much more common to be seen in the pediatric population. Okay, so this is just a picture that I took from my own laboratory, and you might say, hey, your centrifuge is broken because you have a lot of residual red blood cell stuck on the side of the EDTA tube, which is the purple top tube. And the answer to that is no. You'll note that on the right tube here, that the plasma color is starting to look rather icteric. That is not what a light lager beer should look like. But these here, even at the just normal human vision magnification, what you really are seeing is very, very small microaggregates of red blood cells just agglutinating all throughout. So let's take a look at what that might look like under the microscope. So here's a low power view at 10x of a right stain. And what you'll notice is that there's a tremendous amount of blank or white space. That's just light transmission coming through because this patient is anemic. The other thing you'll recognize is it kind of looks like that there are clusters or clumps of these cells located throughout. And again, we'll take a deep dive as to that. But again, I don't think anyone would argue that this patient is anemic, but we'll have to figure out what the etiology of that is. So just going at a little bit higher power, you'll see quite a lot of agglutination. You see these kind of larger clumps. And again, it stands in stark contrast with things like rouleau, which are stacks of coins, typically 5 to 8 red blood cells neatly on top of each other. This is not rouleau. These are aggregates of red cells that are just stuck together. And we'll spend some time talking about why that is in a second. Here's just a high power view. Again, that is not rouleau. That's not a neat stack of coins. Those are red blood cells that are just smashed on top of each other because of the immune-mediated mechanisms. Okay, so what are some just general issues to consider when evaluating patients for autoimmune hemolytic anemia? Well, remember that although we've kind of just touched on a few of the etiologies, um, you can have any isoform causing immune-mediated hemolysis. However, there aren't readily available laboratory reagents to test for things on a moment's notice in most hospitals for IgM. You're looking for a subset of the IgM reaction, in that case complement, or IgA. So sometimes patients or clinicians will say, well, can't you have a DAT negative autoimmune hemolytic anemia? And the answer is yes, because it may be IgA mediated. So remember, we're only routinely testing for IgG and complement. I'll show you some examples of that across US institutions. So that's the first problem. Second problem is that these categories are not really mutually exclusive. So oftentimes people will say, well, look, I see complement deposition on the cell surface and no IgG, therefore it must be cold agglutinin disease. And the answer is, well, that's not the case. As I've shown you already, in cases of warm autoimmune hemolytic anemia, you can see that in about a quarter of cases. So, and it's important to know that because the treatment modality can be very different. The last problem is that each reagent has its own sensitivity and specificity, and different laboratories are using different reagents. So are you doing this interpretation on gel microcolumns or manual or tube testing? And it makes it very difficult to correlate results with laboratory as well as do any type of hospital-hospital comparison unless you know exactly what their diagnostic laboratory is doing. The other thing to remember about general issues in autoimmune hemolytic anemia is that these antibodies may bind at different temperatures, but they may lyse at different temperatures than where they're binding. Again, paroxysmal cold hemoglobinuria being the kind of classic case of that. So we're typically in the diagnostic laboratory only testing at one temperature, typically room temperature. And part of the reason why we don't do this too often is because it can be very time intensive to both cool specimens, but also to warm them. Um, and we'll talk about why certain antibodies you can identify but may have no clinical relevance. Okay, so what about some antibody basics for cold agglutinins? Well, cold agglutinins are just antibodies that recognize and bind to red cell antigens at temperatures that are below core body temperatures. It's typically 4 degrees centigrade, and most people in the lab will be very well familiar with this. US FDA regulations for storage of red blood cells, if you have a walk-in refrigerator or a cooler, are between 1 and 6 degrees. And so it's very easy for us to cool down specimens because we can just incubate it in our refrigerators. But when we look at cold agglutinins, a lot of people have cold agglutinins. If you take a lot of samples from healthy people, blood donors, or just relatives of patients, and you take their sample and cool it down to 4 degrees centigrade, you'll find that. That does not mean that they have cold agglutinin disease. Remember, cold agglutinin disease, you can kind of think about it, breaking it down between both primary cold agglutinin disease, that's just a hemolytic process resulting in anemia without an underlying disease process, or you can have secondary cold agglutinin disease. This is typically hemolysis following a viral infection, autoimmune disease, or hematologic disease. So we'll touch on these. What about clinical features of cold agglutinin disease? It tends to be more female mediated. The classic case is a female in her 70s. Symptoms are again anemia. Um, you can have dyspnea on exertion, shortness of breath, fatigue, weakness, or acrocyanosis. Hemolysis, so it can be predominantly extravascular hemolysis because of the complement deposition, but remember that not every case reads the textbook and you may get intravascular hemolysis as well. Laboratory testing is typically positive for C3, and there are different C3 breakdown components that you may be testing for, whether it's C3D or C3B. Cold agglutinin disease not only requires you to have the typical IgM isoform, and this typically will target the eye, the big I or little I antigen. For those that are not familiar with this minor red blood cell antigen system, this is just a carbohydrate chain that shows up on red blood cells, typically cord red blood cells or red blood cells taken from cord blood samples tend to have very low branching complexity, which we would call the little I antigen. As we age, you have more carbohydrates, you get more or higher degree of complexity and branching, and we would call that the big I antigen. And that transition typically happens around between 2 and 4 years of life. So these antibodies can be monoclonal in nature or polyclonal. For them to be clinically impactful, they typically have to have high titer and broad thermal amplitude, and we'll talk about that. And the incidence of this is typically 1 case per million people per year, and it represents about 15 to 20% of all cases of autoimmune hemolytic anemia tend to be cold agglutinin disease. So I don't really like this added, but people will often say, "Isn't this a benign disease?" And broadly speaking, it is not a malignant disease, but this disease, although benign in nature, can cause a serious amount of morbidity and potentially up to mortality. Remember that a lot of these patients will require transfusion support, and that's not always the easiest thing. Um, and up to 20% of them will have a thrombotic event. And you can have cold-induced circulatory symptoms and anemia that have negative impacts on their quality of life, particularly in colder winter months. So what about board exams or things to be cognizant of when evaluating the patient? You can have a lot of viral or post-viral related associations with autoimmune hemolytic anemia, particularly cold agglutinin disease. People that have anti-big I may have a recent history of mycoplasma pneumonia or concurrent mycoplasma pneumonia, like a walking pneumonia, or little I for patients with EBV or EBV type influenza-like illness. There are also rare cases of anti-PR or pronase-related antibodies that have been identified in patients with zoster or rubella. There's not a lot of evidence to support or refute patients in the post-vaccination state, but just be aware, people have access to Google and they will Google it. HIV, a lot of patients with HIV will have a positive DAT. Review papers will often speculate between 40 and 60% of patients with HIV will have a DAT positivity, but most of the anemia in those cases is typically because of their chronic disease. Other associations, including hepatitis, parvovirus, are vanishingly rare. So what do we typically see in the laboratory for cold agglutinin syndrome? Again, your direct Coombs tends to be IgG negative, but you will see C3 complement deposition on the cell surface. And then we go through testing at different thermal amplitudes. So you can test at 4 degrees, you can test at room temperature, 30 degrees and 37 degrees. Uh, Most people will report out results that are at 30 degrees. So you really need a few things. You need both the IgG isoform that's resulted in the complement cascade activation to get that complement deposition on the surface of the red cell, and you need a high enough titer across a broad enough thermal amplitude for this to be clinically impactful. So let's talk about what kind of clinical impact they have when we try and talk about whether or not healthcare providers are accurate in their ability to identify when they should be ordering this test. So myself and a few colleagues at Barnes Jewish Hospital in St. Louis, Missouri, as well as in the Harvard teaching hospitals, got together and started to look at diagnostic laboratory testing and whether or not our healthcare providers do a good job of utilizing expensive hospital resources to avoid iatrogenic blood loss or wasting of resources. So, what did we do? We took a look at 3 different institutions. Vanderbilt is where I'm at, Barnes Jewish Hospital, and Massachusetts General Hospital. We performed a retrospective analysis for cold agglutinin disease testing in blood bank specimens, looking at approximately 800 patients. And you might say, well, why did we do a 3-institution site? It's because this is, again, not a very common disease, and so you need multiple specimens in order to have any kind of clinical analysis that would be impactful. And we were looking to see whether or not clinicians are screening anemic patients for cold agglutinin disease with a simple DAT at first, or do they jump in and ask for more complex or resource-intensive testing, including titers or thermal amplitude evaluations. So the methods of our study were just to review DAT results at all 3 institutions within 1 week before a cold agglutinin disease testing was undertaken, and looking to determine whether or not you ever had a positive reaction with C3b or C3d, and that would be our what we considered a true positive. So here's a breakdown of how did the DAT results come out and what subset had unnecessary cold agglutinin testing. So we had about 800 patients, and again, on the left-hand side of the screen, here are about half of the healthcare providers had never performed a DAT. They just went straight to wanting to know the thermal amplitude and the titer for cold agglutinin. Contrast that with the other half of people that were ordering a DAT. And if you follow this down here, if you have a DAT that has a positive for complement deposition, then doing a titer analysis. So this would be the preferred pathway following it on to the right, and this would be the least desirable pathway on the left. And let's talk a little bit about what the clinical implications of that may be. So there's the different sites, Barnes-Jewish here at Vanderbilt and MGH. And again, taking a look at whether or not any patient had a direct antiglobulin test within the last 7 days. And you'll see that, about 2/3 at Barnes-Jewish, about 1/3 at Vanderbilt, and about 40% at Harvard had that. And then if you look down here, for those that had a positive DAT with complement, again, pretty good. This is what we would like to see, and then we can do the titer. But drop down here where the red arrow is the negative predictive value of a DAT with C3. So if you do not have complement on the surface of your red cell, you can be very, very confident that you do not have cold agglutinin disease. In fact, of the subset analyzed here at Vanderbilt, 100%, which was consistent at Barnes-Jewish at 97 and 99 at Mass Gen. So what would be a good screening test? Well, the optimal screening test would be something that would be inexpensive, should be readily available, and have a high negative predictive value, which is wonderful because if you are ordering this testing algorithm correctly, a negative DAT for when you're using monoclonals for complement has a very high negative predictive value. If you had a concern for, does this patient have clinically significant cold agglutinin disease? You'll note that we observed a similar frequency of elevated cold agglutinin titers in patients with and without a DAT result, approximately 12 and 10% respectively, suggesting to us that clinicians who order cold agglutinin testing without a recent DAT do not actually have a higher pretest probability of cold agglutinin disease than clinicians who order the DAT before or concurrently with cold agglutinin testing. This becomes a significant challenge as often healthcare providers are reluctant or reticent to order a series of tests, wait on those results, and then have the patient come back in for appropriate follow-up. In today's healthcare environment, particularly in the United States, what you'll find is ordering a lot of tests at one go with an eye towards or in hopes of saving the patient some amount of inconvenience. That inconvenience must always be balanced with the fact that these are, again, resource-intensive related tests. They are not free, they are not cheap, and in some cases they're not necessarily easy, but you may also get a clouded picture of results and you may not be able to make an educated assessment thereafter. All right, so switching to primary versus secondary cold agglutinin disease. It's always a good idea when evaluating a patient in this subset of diseases to consider, again, underlying diseases or disorders. So is there an infection? What kind of respiratory symptoms, if any, were happening? Again, their age. Was it an atypical pneumonia, like a walking pneumonia that you may suspect in the teens, 20s, or 30s for people with mycoplasma? Or other autoimmune-related diseases like joint pain? Do they have a malar rash across the bridge of their nose? Or any type of lupus-related serologies may be useful in evaluating these patients. And then obviously hematologic disorders, things to consider including non-Hodgkin lymphoma or Waldenström's macroglobulinemia. Do they have any B-type symptoms including weight loss or lymphadenopathy, hepatosplenomegaly, and what's been going on in their urine, and taking a look at light chains, or in their plasma looking at SPEPs. So laboratory testing that's done in cold agglutinin disease, again, when you have secondary causes, you'll be looking for infection or autoimmune disease. These typically have a polyclonal process so that if you can get a hold of their underlying disease, or if it resolves, typically you don't have to do anything thereafter. Very infrequently will they require a significant amount of transfusion support, but you may advise them about avoiding cold temperatures or traveling to cold regions. Cold agglutinins associated with lymphoid malignancies or hematologic malignancies, any type of lymphoproliferative disorder, may require certainly additional evaluation, including bone marrow, and may very well be monoclonal and will not resolve spontaneously. And we'll talk about some treatment options at the end of here. But remember, cold agglutinin disease, unlike warm autoimmune hemolytic anemia, typically are not responsive to glucocorticoids or splenectomy. And these people can have significant hemolysis. So we'll talk about what to best do in those situations. So I generally think about treatment for this disorder and think about what can be done immediately or readily available or cheaply. Again, cold avoidance, so avoiding cold environments, and we'll talk a second about the operating room. This may be very simple, including covering or layering patients with a bare hugger or warm, and avoiding cold beverages or food. Obviously, where you are is going to be very impactful in terms of the type of care you're going to be able to deliver. So warm IV solutions, whether you have a blood warmer or just running a non-contact solenoid coil to keep the fluids that are going into the patient warm. Um, a lot of blood banks are not responsible for the maintenance of blood warmers throughout the institution. That's typically clinical engineering. So you may call the blood bank and ask for a blood warmer, but most blood banks are not doing the QA, QC for these devices. And if it's anything, if your institution's anything like mine, finding a blood warmer can actually be a significant task to begin with. Surgically, it's always important to remember the temperature of the room. Most surgical rooms can be pretty cold, particularly if you are going into an operative theater that's engaged in any type of chest procedure, particularly cardiac procedures. So advising them about warm cardioplegia-related solutions and the possible need for emergent plasmapheresis. So just again to touch on for cold agglutinins and cardiac surgery, remember that bypass-related surgery are typically deliberately causing hypothermia, where they will lower the core temperature, particularly around the coronary circulation, where temperatures can be approximately 10 degrees centigrade. So, this is not an infrequent question that we get. Do you worry about lowering the patient's core body temperature to the point where these cold agglutinins, again, the IgM isoforms, can cause significant hemolytic anemia? Um, and the short answer is no. I wouldn't advise cardiac surgeons or cardiologists to be screening all of their patients for cold agglutinin disease. It is a very low predictive value. Again, this is a rare disease, and estimates for the institutional cost just to perform unneeded screening can be about $20,000 a year. Now, but what modifications can be done for cardiac surgery? Well, there are a ton of case reports out there, but you may want to lower the titer of the cold antibody before surgery. This can be done most expeditiously when using plasma exchange. If you have enough time or the patient is relatively well, you may consider other means, including immune modulatory therapy. If it's in the operative theater, trying to keep the systemic temperatures above what you've found in terms of the thermal amplitude of the cold antibody, or the duration of the intracoronary exposure to cold cardioplegia may also be shortened. They can do washouts to try and make sure that the cold solutions are not essentially recreating a laboratory incubation type scenario. Or you can simply avoid the cold temperatures altogether. There are surgical procedures that will use normothermic solutions, or even warm cardioplegia related solutions that are favored by some. All of these options are heavily written on in the medical literature, with no one solution being better than the other, and what works for you may be a combination thereof. So what about the use of therapeutic plasma exchange? Again, as with most plasma exchange interventions, there's no clinical trials here. That doesn't mean that there's not evidence to support it. The American Society for Clinical Apheresis qualifies this as a Category 2 indication. The good news is that typically humans' IgM isoform is largely intravascular. It's a large pentameric protein, and you can very quickly exchange this out and replace it with healthy donor plasma or a combination of normal saline and albumin as you see fit, depending if the patient has any underlying coagulopathy. But you may need to do more than one exchange, so just be aware that. And the other thing is that this doesn't treat the underlying disease. So when should you perform this? This is typically something that should be done 24 to 48 hours before any scheduled cardiac or perioperative start time, such that you have enough time to reevaluate both hematologic indices via CBC, the need for transfusion support, or they may need another exchange depending on how high the titer result was during your initial evaluation. This is just something that everyone sees in medical school and nursing school, the pentameric structure comparisons between IgG isoforms and IgM isoforms. Remember the J chain linking together all of these moieties to make a very large structure. This is just a different model so that people can have a visualization so that they're comfortable with that. What about therapy to reduce or eliminate the antibody source? Most patients with cold agglutinin disease that have an infection are likely to have a polyclonal cold agglutinin, and as I said, this typically will resolve spontaneously. It can take a few weeks. In some cases, it can take a few months. That largely is dependent on their clinical course with whatever their underlying disease was. But what about those that have a clonal cold agglutinin disease IgM isoform antibody? Well, obviously, if they have a malignancy, this needs to be evaluated and treated. But what happens if you evaluate them for malignancy and you can't definitively land on a diagnosis of a malignancy? You can still have a monoclonal cold agglutinin disease that warrants a treatment, particularly for those that are severely anemic. So if you have cold agglutinin disease without an underlying malignancy, most providers will focus on treatment regimens that contain Rituximab and Bortezomib, which are used to treat the lymphoproliferative disorder in the marrow. Remember that when we compare autoimmune hemolytic anemia subtypes, warm autoimmune hemolytic anemia is the most common and tends to be responsive to steroids and splenectomy, depending if the patient's old enough or surgically capable of tolerating splenectomy. But this is typically not effective treatment for patients with cold agglutinin disease. So what are some of those rituximab regimens? Are there examples where there are low-dose rituximab that can work? And the answer to that is yes. There's slightly better response that's seen in warm autoimmune hemolytic anemia, but you can still have a sustained response in reducing the circulating anti-red cell antibodies. There are other case series that have been published. Rituximab was associated with the longest response to duration. Again, this can be an outstanding response up to 2 years, but it may prompt patients thereafter. So again, appropriate follow-up is a good idea, and you should be checking a direct antiglobulin test for complement deposition to see if it's coming back. Because as indicated on the slide, about half of the patient population will still require further treatment. Well, what about if you have rituximab and you want to add in another agent? There are many different to choose from, including rituximab plus bendamustine, which has a response rate of about 70%, and you'll see a complete response in approximately 40% of your patient population. The downside to that, as you might imagine, is that patients can become pretty severely neutropenic, which then begets its own set of problems, including potential infection. And this is further complicated if patients have indwelling lines or central venous catheters. What about rituximab plus fludarabine? Response rate slightly better, maybe not statistically significantly better than bendamustine, but response rates are around 76%, with complete response rate slightly lower at 21%. But again, there's always a downside. That downside here is grade 4 hematologic toxicity. When you have an absolute neutrophil count that's less than 500, people start to get pretty nervous about ongoing infection, whether it's bacterial or fungal, which can be clinically devastating. What happens if you just want to take rituximab and add on steroids? Response rate is pretty good, about 90%, but again, about a 30 will relapse in about 24 to 2 years amount of time. If you're willing to entertain this idea, rituximab plus interferon, response rates of about 50%. On the case series that I identified, no serious adverse events reported with that, although I would say anytime you're getting interferon, you're probably going to have some pretty serious side effects to begin with. So what about other agents? Bortezomib. Bortezomib is a proteasome inhibitor that's largely used to treat B-cell malignancies. The evidence for utilizing this agent was published last year in the journal Blood, involving 21 individuals with cold agglutinin disease who had anemia, typically chronic hemolytic background with hemoglobins under 10 grams per deciliter, which one prior treatment had already shown that they were refractory to. The good news is you can get a little bit of a response out of these patients. Typically about a third had a response rate and lasting just over a year. There was one reported serious adverse event of an upper respiratory related infection for a patient on this medication. What about future considerations for treatment? Are going to be some things that would be important to consider. Efficacy and toxicity have to be balanced with each other, particularly for patients with cold agglutinin disease in their prior disease state. Non-chemotherapeutic options, including other monoclonal related antibodies and other targeted therapies, are still being evaluated. And you may also have for patients that are highly refractive, you may consider, can you shut down the complement cascade, eculizumab? There are case reports of that, although in the United States, the cost of that medication is very expensive, so should be a huddle before making these types of decisions for treating cold agglutinin disease with some of these medications. With that, I'm going to wrap up, see if there are any questions from the audience. Also, just want to make sure that everyone's aware. There are additional free online educational opportunities. One website that I help run is transfusionnews.com. There's a question of the day part in that. 3 questions per week, Monday, Wednesday, Friday. It goes from easy, moderate to hard. And within that, you'll be able to find questions related to autoimmune hemolytic anemia, transfusion reactions, blood products, transfusion adverse events, and everything in between. With that, I'll open it up to the audience and see if there are any questions. You can type it into the chat box, and we'll go from there. Some of the common questions that I get related to cold agglutinin disease are whether or not it's going to be intravascular or extravascular. Remember that once you have IgM being bound, it can activate the classical pathway of complement, which can result in C3. But rarely do you have enough complement to actually form a membrane attack complex, the C5 through C9. But when you have complement on the surface of red cells, this can opsonize these cells, meaning that they are a target for removal. Most of this removal can largely take place in the liver, which a subset of patients may ultimately have hepatomegaly. So some things to consider, when patients or providers may say, well, is this going to activate the membrane attack complex? In most situations, that's not the case, but you can see a pretty significant hepatomegaly in very serious cases. With that, I'll see if there are any burning questions from the internet world. And again, thank you for your time and your interest in this topic. And again, thank you for the invitation to speak to you all. I'm going to look over at the chat box to see if there are any questions there. I don't see any questions at this time. Well, I want to thank you all for your attention, and I want to thank you again for your participation. For those that are watching this online in a banked or reference section, thank you for downloading, and I appreciate your time. Have a good morning, good afternoon, good evening, and thank you so much.